Right. Hi, everyone. Welcome to this webinar titled What is Patient Blood Management and Practical Applications of Critically Ill Children. We have a filled agenda for you all today in the next hour, and so we will go ahead and stay on time and begin. So these are our learning objectives. They are the same ones that are listed in the flyer that you guys all received. And so the webinar outline will begin with an introduction from our ESPNIC colleagues. We truly have wonderful speakers today, which I'll introduce before the respective sections. Additionally, I just wanted to apologize for the time zone error that I made on the flyer. For those who are registered but unable to attend this morning, or if you just want to review the material after the event today, a webinar recording will be made available at the bloodnetresearch.org website under the term webinars. And so with that, I wanted to introduce Dr. Fabrizio Chiosolo and Laura Butragueño Laiseca, who lead the European Society of Pediatric and Neonatal Intensive Care Blood Management Working Group, and they are also practicing intensivists in Rome and Madrid, respectively. So they're going to take over and tell us about their ESPNIC work.
Thanks, Michelle.
The floor is yours.
Hello, everybody. We are very happy to have this webinar as a collaboration between the BloodNet and ESPNIC. And for those who don't know what is ESPNIC, I'm going to explain it very briefly. ESPNIC is the European Society of Pediatric and Neonatal Intensive Care. It was created in 1980 with the mission of promoting the delivery of the highest quality of care to critically ill children in Europe. As an European society, members are mainly from Europe, but we have members from all over the world. Whether if you are a physician, nurse, or other healthcare professional working in NICU or PICU, you are more than welcome to join the society. Next, please. The society has several scientific sections as well as working groups that you can see listed here. Each section promotes their own educational and research projects. And one of these working groups is the recent hematology or patient blood management working group that Fabrizio is going to tell you more about it.
Next, please. Hi, I'm Fabrizio, and our group is young. It's formed in 2021 from an idea of Laura, and we are sharing the group. We have 59 active members, and actually we are waiting on June, the last week of EPITA study. That is our project for European Pediatric Transfusion Practice in PICU. And there are more than 40 centers participating, and we hope to have interesting results. Thank you to Marianne for collaboration, and so Laura and me will spread with ESPNIC monthly mail the METIC-ONCO project on massive bleeding in children with the cancer and or hematopoietic stem cell transplant. More than 25 centers across the world, and it will be a big project. Yes. Next, and don't forget the main congress of ESPNIC that we have every 2 years, and it will be held in Athens from 20 to 23 of June in Athens, and our group will meet on 22 of June in the afternoon. We will organizing the participating to the meeting by home, by virtual. So people interested will receive the link for participating and join our ESPNIC group. And thank you to Marianne, to BloodNet for sharing this idea of webinar, and let's go. Thank you.
Thanks, Fabrizio. So in order to join ESPNIC, we can just email you, is that, or not, in order to join the PBM ESPNIC working group, we just email you at the links there?
Yes, actually we have our email, yes.
Sounds great. Sounds great.
Can I just add something, Michelle?
Yes, please.
So normally to be part of ESPNIC, you need to be part of ESPNIC. Their fees is extremely low compared to the American societies. So it's like much less expensive than being a member of STCM. And if you are interested in joining ESPNIC, there is a group of ESPNIC members on this side of the Atlantic. And so I am sort of organizing this group because we want to be represented within ESPNIC. So if you are interested in joining ESPNIC, please reach out to Laura and Fabrizio, but also to me, because I'd love to know who wants to be a member of ESPNIC.
Thanks, Oliver. Cool.
Thank
Awesome.
you.
Thanks, Oliver.
Thank you.
And that being said, hopefully this is not the last partnership that we'll have between your group and BloodNet. So with that being said, I'm going to stop sharing and introduce our next speaker, Dr. Stacy Valentine. She is an associate professor at the University of Massachusetts Medical School, as well as really an expert in pediatric patient blood management. And so she will be talking about, is it needed and what is it? And is the term correct?
Thank you so much, Michelle. I'm very excited to be here. And as you've said, I'll be talking about pediatric patient blood management. Why is it needed? And we can talk about the term and we should rename it. No financial relationships to disclose. So just to start off with, I think we all know blood is a precious resource and transfusions can absolutely be life-saving. They can also absolutely cause harm. And the risk, benefits, and alternatives of transfusion must be carefully weighed with every transfusion every time. So patient blood management, the term has been coined by by many societies, ones that I'll quote here from the Society for Advancement of Blood Management, as well as AABB. And so they define it as the timely application of evidence-based medical and surgical concepts designed to maintain hemoglobin concentration and optimize hemostasis, minimize blood loss in an effort to improve patient outcomes. And the AABB, it encompasses all aspects of patient evaluation and clinical management surrounding the transfusion decision-making process, including the application of appropriate indications, as well as minimization of blood loss and optimization of patient red cell mass. When I think about patient blood management, I think about the four pillars, and this is from the Society for Advancement of Blood Management. And I like to think about it as a multimodal approach. And so when you think about patient blood management, we should think about our transfusion thresholds and make sure we're following guidelines. Blood conservation, how do we keep that blood? Anemia management, how can we augment and treat anemia, and then hemostasis management. And this multimodal approach, if we consider all of them, the goal is to improve outcomes and hopefully decrease transfusion. So to transfuse or not to transfuse? Well, there have been two major initiatives that have looked at transfusion and created transfusion consensus. This is TAXI and TAXI-CAB. And really the basis is to create evidence-based. When evidence is lacking, expert-based consensus on blood management strategies for clinicians caring for critically ill children aim to maintain a physiologically relevant hemoglobin concentration, optimize hemostasis, and minimize blood loss. So you'll hear about those themes throughout in terms of patient blood management. And in TAXI and TAXI-CAB, the first series focused on red cell transfusions, the second focused on hemostatic blood product transfusion. It was an international multidisciplinary group of experts on pediatric transfusion and included many of those disciplines: anesthesia, cardiology, cardiac surgery, hemonc, transfusion medicine, trauma surgery, neurology, neurosurgery, and especially engaged the experts on guideline development and implementation science, which you'll hear later from Kate Stefan on the importance of that. So I like to show the two decision trees, and this is thanks to our Kate Stefan, who's on here with implementation science modalities, was able to help us put almost all of our recommendations into this transfusion decision tree. And so this, I urge all of you to be able to use whenever you're considering a transfusion for children. It's important with patient blood management to think about, do I need a transfusion for this child? And the decision tree allows you to walk through that decision-making process. It also gives you the relevant hemoglobins, and then also provides the level of evidence. It's important to know which are backed by moderate quality pediatric scientific evidence and which ones are expert consensus. And through this, you'll be able to walk through that decision making. And incredibly important to think about that each time you're going to transfuse. And then similarly, Marianne Nellis led Taxi Cab, and she created this beautiful transfusion decision tree, which the same way you could think through your transfusion decision making and walking through. It's important to think about all of those different parameters and whether a transfusion is indicated, needed, or not indicated. And the same thing with transfusing red cell plasma and platelets. And so these will be made available to you. And I urge you to use these decision trees whenever you're thinking about transfusion. So that's the first part about patient blood management, is those transfusion thresholds. The second is blood conservation. And we know that phlebotomy is increasing phlebotomy is associated with transfusion requirements and is associated with need for transfusion and then worse outcomes. And so it's important with awareness of phlebotomy practices, we can lead to decreased blood loss in critically ill patients. And so thinking about patient blood management, we want to conserve the blood we have. We want to use those transfusion guidelines to transfuse when we need to. Next is anemia management, and really thinking about managing anemia, managing preoperative anemia, as well as hemostasis management. And this, I look to my colleague, Susan Gooby and Thorsten Haas, who have looked at preoperative outcomes in pediatric patients. And I like their multimodal approach and really thinking about preoperatively to recognize, diagnose, and treat anemia, considering stimulating erythropoiesis, and then implementation of a patient blood management program. Interoperatively, to use your restricted transfusion practice, so go back to those transfusion algorithms, to utilize what's called a massive hemorrhage protocol. And I like Susan's approach to this because it's not a massive transfusion protocol, but it's really thinking about how to prevent that hemorrhage. And when you need to transfuse, you follow that algorithm, and optimizing surgical techniques, antifibrinolytics. And then post-operatively to treat and tolerate anemia, to use a restricted transfusion practices and to tolerate coagulopathy. So really thinking about that multimodal approach. And this is courtesy of Susan, really thinking about that multimodal patient blood management approach to thinking about in the operating room. And it is really a group effort with your anesthesiologist, surgeons, and thinking about patient outcomes. So in summary, because I want to get to the rest of this webinar, blood is, transfusions absolutely can be life-saving. They also can cause significant harm. And the goal is to utilize these patient blood management strategies, use your transfusion threshold guidelines, blood conservation, hemostasis management, and importantly, every time weigh the risks, benefits, and alternatives of transfusions carefully with every transfusion, with every decision. And I'll go back to you, Michelle.
Thanks, Stacey. So if any questions come up, feel free to put it in the chat, or you can unmute yourself and ask. The next section is going to be interactive, and so I hope that a lot of you guys will be able to do that. So we're going to talk about practical applications through some cases. And the people who are going to be presenting is Dr. Simon Stanworth. He is a professor of hematology and transfusion medicine at Oxford. His colleague, Dr. Abhishek Sarfati, who is a pediatric intensivist, also at Oxford. And then also Marianne Nellis, who leads BloodNet, as well as at Cornell. So that being said, you guys can share your slides and we can go through kind of these applications through cases.
Okay, hello. So hopefully you are seeing my slides now. Is that right?
It looks perfect. Yeah.
Yeah. Oh, fantastic. Okay. So welcome and thank you everybody for joining. So I'm just going to go through a few cases that hopefully will be familiar to people and raise some of the questions around when to transfuse and when to give blood products and when not to. And I guess through all of these the two guiding principles are, why are we transfusing, be it red blood cells, where we are primarily aiming to increase oxygen delivery to tissues, or whether we're giving plasma or platelets, trying to avoid episodes of bleeding. And on the other hand, weighing the disadvantages of giving the various blood products. So the first case that we have here for you is a 6-month-old girl who is an ex-prem, was born at 26 weeks, so she's now about 2-3 months old, corrected. She'd been on home oxygen since she's been discharged home. A month ago, she was admitted to the pediatric ward in Oxford with RSV positive bronchiolitis. Initially was following the standard course, but overnight had increased vocal breathing, increasing oxygen requirement, and our outreach team from pediatric critical care was called to see her. She was on 2 liters per kilo of high flow oxygen in 80% oxygen and saturating about 92%. So the team decided to transfer her down to our high dependency unit and to give her a trial of CPAP. And after some time on CPAP, they've done a blood gas, and that showed that really she wasn't getting much better. She's now in 90% oxygen, saturating 91%. And the decision was made to intubate and ventilate. And importantly to our discussion today, on her blood gas, her hemoglobin is 85. And I think we would all agree that probably at this point we wouldn't offer her any blood products. Over the next 72 hours, she's on the whole easy to ventilate, but quite difficult to oxygenate. And what I want to highlight in these gases is that hemoglobin stays around the same as before. It's 86 now. And we are working considerably harder to deliver oxygen. So she's on a PEEP of 7 and in 60% oxygen. We're achieving a 91% saturation. And the question, again, that was raised to me actually by one of our juniors, is whether to give any blood transfusion at this point. And I'll talk a little bit about how we make this decision, but I do wonder what people think, whether people would be transfusing a child with these numbers or not. I guess from my perspective, the important thing is whether she's symptomatic, whether she's tolerating this anemia, whether we have evidence that she's not tolerating this level of anemia. And reassuringly, this was a venous saturation, and the lactate was okay, and the mixed venous saturation was 71%, which suggests to me that she's still managing with this amount of oxygen. However, she then continues to deteriorate, and she's now a day on, and she's now on a PEEP of 8 and in 85% oxygen. And this is still achieving similar saturations. However, the mixed venous saturation is now 58%. So really it shows us that she is extracting as much as she can out of this hemoglobin. And the question is what people would do now, whether people would feel that they would transfuse her at this point with a hemoglobin of 78 now. And I think, to me, these sort of patients are, in my clinical practice, I probably would give them a blood transfusion. I will try to explain a little bit why. So what do we rely on? And you've already seen the taxi recommendation, but importantly, what I've circled there is the severe pediatric ARDS, where it says to use clinical judgment. And if you look at what the recommendation says, it says that we don't transfuse if the hemoglobin is is above 7, then we don't transfuse. However, critically ill children with respiratory failure and severe hypoxemia, we cannot make any recommendations. So it is down to us to make that decision. And talking more broadly about the recommendation about transfusion threshold of 7, it's important to highlight again a study that I'm sure most people will be very familiar with, is a TRIPICU study, which looked at, which was an RCT that looked at transfusing children at a threshold of 7 for a restrictive threshold versus 9.5. But importantly, this study was it screened and found over 5,000 children that would have been eligible in the sense that they met the cutoff hemoglobin of 9.5 grams. However, only 648 children, so a little bit more than 10% of the children that were had the appropriate hemoglobin to be included in the study were actually included in the study and actually underwent randomization. And there were multiple exclusion criteria, but importantly, some of them were ones that reflect the more sick and the more unstable children in our ITUs. So the decision not to transfuse these children and to use a hemoglobin threshold of 7, which is what has crept into common practice, has not very strong evidence behind it. So what did the study show? There were 317 children in one arm in the liberal group and 320 in the restrictive group. But the hemoglobin, the lowest hemoglobin in each group before transfusion was 10.8 in the liberal group, but actually was still 8.7 in the restrictive group. And yes, the restricted group received fewer blood transfusion episodes and the outcomes were no different. But really the important thing is that a lot of this would convince me that with the patients who is stable on ITU, I would be happy to follow this number. But with the ones who are more unwell and more unstable, I would look to make sure that they are tolerating this level of anemia. And then finally, an important question for all of us is about what do we do with these patients at discharge? And this is something that's increasingly concerning me because we are restricting the use of blood products more and more, which I think is appropriate. But we end up discharging a lot more patients with significant levels of anemia. And often when we audited practices in our unit, often this wasn't recognized and no follow-up or management plan was instituted for these sort of significant levels of anemia. So this was the first case, which I think represents quite common type of patients with COPD-ICU. The second case that we wanted to bring forward to everybody's attention today was a child again that presented to our ED. This child presented with fever, tachypnea, tachycardia, very pale, had some non-blanching rash and some bruises on the arms and the legs, a large liver, large spleen, no obvious acute bleeding. She again was about 6 months old, but of note had very abnormal lab results with a hemoglobin of 34, platelet of 23, and a low white cell count. The working diagnosis was that this is very likely to be a new presentation of ALL, and there was a plan instituted. And later on, we had a blood film that was suggestive of blasts, things became clear in terms of the diagnosis. But the question remained about what to do with these lab results and should we be transfusing these patients. And so these are the labs that came a short time after she presented to ED. And you can see that on the whole coagulation is okay, but the hemoglobin is very low, platelets are low. And really, I wonder what would people think, what would they do about this type of patient? Would they give them red blood cells? Would they give them platelets? Would they give them anything else? And again, going back to the taxi recommendation, sort of wondering why really oncology patients are any different to our critical care patients in their need for transfusion. The recommendation is based on really very, very weak evidence and talks about transfusion thresholds of 7 to 8, maintaining the hemoglobin at 7 to 8. And I guess the important thing here from my perspective is to be very mindful that we're not just treating a number, that often this is a chronically evolving anemia. And what is really important to my mind is to ascertain whether the patient in front of you is symptomatic with this level of anemia or not. And obviously in this patient, she was tachycardic, she was tachypneic, and so were acute concern, and the hemoglobin at 34 is very low. And finally important is what is the trajectory? If this patient is going to undergo procedures, if this patient is going to have a lot more blood sampling, then obviously we expect that number to go further down. So I would agree with the recommendation to give blood, and I would, in fact, transfuse this patient. But I think the 7 to 8 is fairly arbitrary, and I would be cautious about giving large volume of blood products and correcting that number too quickly. The next question is about the platelets, and the platelets were 23. And when it comes to platelets, we need to ask ourselves, why do we give patient platelets? And really, the main reason we give our patient platelets is because we want to avoid them bleeding or to stop them bleeding if they've already started. And what does the evidence say? And again, what we have here is the flowchart decision-making tree from taxi cab. And interestingly, I'm of course not going to go through this, but if you look at the bars that are color red, these are the ones that says do not give any products, any platelets, and the one in green that says please do give platelets. And everything in between, in gray or in yellow, is either clinical judgment or you can consider this. So really, we have not a huge amount to go on in terms of deciding when to give platelets to these patients or not. But still, we need to make a decision. And I guess the difference is between patients where we are treating a low number prophylactically to avoid the risk of bleeding, the ones where we are intend to perform some invasive procedures, and then we think they might bleed in that, or and that might be a complication, and we want to minimize that complication. And obviously, very different are the groups that are already actively bleeding at the time. So what does the recommendation really say if we try to look more into them? And what we generally follow is that we would generally prophylactically keep the platelets above 10. For invasive procedures, I would, well, it depends on the invasive procedure, the answer is. Because for me to put a central line is very different to performing a lumbar puncture. And I guess if we are going to perform a lumbar puncture fairly arbitrarily, I would use a cutoff of 50, and I would try to transfuse the patient. And we do have some data from the US in a paper by Chang that describes patients with platelets less than 50, and actually show that whilst we had more traumatic taps when the platelets count was less than 50, actually we didn't have any more complications. And then, sorry, just one moment. And then the less than 20, I usually would give them platelets. And then in the one that are actively bleeding, this is where the evidence, or not the evidence, but the recommendation is a little bit clearer, and is to give platelets above 50. And I think that's a reasonable way to go forwards. Thank you very, very much. There was a lot more that we could have discussed, because there are a lot of different cases and scenarios where we use blood products and different considerations in each of them. But we thought that these would be raise interesting points, and I hope you all enjoy them. And please, very happy to answer any questions.
I think we might have a little time, Michelle, right?
Yeah, we do.
So-
We're doing very well on time. So I think actually it would be awesome to open this up to discussion for everybody in the chat. There's already a few questions, I think, or comments.
Maybe, Simon, I don't know if you want to start about the randomized control trial in adults from the New England Journal. I think this is about procedures and platelet transfusions, right?
Yeah, very happy to. Hello, everyone. I think this is a trial, randomized trial that came out a couple of days ago in the New England Journal of Medicine. It was trying to answer the question of platelet count thresholds for procedures in adult ICU. So as we've been hearing, levels of data around platelet transfusions in sick children is very thin on the ground. So, you know, we do sometimes, and I think it's quite appropriate that we look to see what can we learn from other settings. So this was a randomized trial undertaken in the Netherlands, and it was looking at, actually, I think, quite a broad range of individuals, young adults, some in hematology, some in adult ICU. It was looking at thresholds between about 10 and 50. I think it's going to be a trial that we're all going to have to read, and we're going to have to make our own judgments about. It did find a little bit more data to support some bleeding in lower platelet counts. But it's very procedure dependent. So I think, as Avishai was mentioning, when he was thinking about the type of procedure I'm going to be doing, I think that data for me comes through very strongly. And I wonder whether this trial's telling us something about the type of procedures. They also didn't find evidence of a relationship as that platelet count gets really low. So when we're talking about platelet counts, below that 20 or 10 level, and the relationship to bleeding. So I think we're all going to have to think about this study. I do wonder whether we need to be a bit smarter about one of these designs, because one of the things that when I'm teaching, I try to get people to think a little bit about is it's not just about the number. If we talk about a figure of 10 or we figure about 20, does that really mean that bleeding risk changes, whether it's 9 or 11? So we have to have some clinical judgment here. And I know, again, data in children isn't very strong, but it's just really to remind everyone, and you may be aware of some of this, but there have been some randomized trials in adult, albeit in adult patients with bone marrow failure, hematologic malignancies. Where actually what we've been doing is asking the question, well, do you need to give prophylaxis at all? Do all groups of patients benefit from prophylaxis? And I think there are some messages here about maybe applying a very common single, maybe one size fits all threshold to some of these patients moving forward. So Marianne, I'd be very interested to know what you think, as I know you led the platelet initiative, but those are just some of my considerations in this difficult topic of how we use platelet transfusions.
Yeah, I agree, Simon. I think it's really important that while the decision trees were probably one of the highlights of Taxi and TaxiCab, and we're trying to promote them and promote their use, both of those initiatives had pretty strong statements that you really have to think about the clinical context of the patient, and not just in red cell transfusion, the hemoglobin level, but really that idea of tolerance of anemia, because every patient's level of tolerance of anemia is different. Likewise, when thinking about plasma or platelets, that each patient's tolerance of thrombocytopenia or coagulopathy is different, and the clinical scenario is different. Certainly for the platelet transfusion trees, we break it down by diagnosis, but our patients fall into many of them, right? Like they're an oncologic patient who's getting a procedure, who might be in DIC and sepsis on ECMO. And so which threshold do you choose? And so it's really hard to just choose one number for these patients. So I agree wholeheartedly and really think the clinical context of the patient has to be considered. And also, for instance, the case of the oncology patient that we presented, weighing the risks of transfusion as well. And what are the risks in this particular patient of bleeding, but also of clotting? And if they're, in this patient we presented, they didn't have a very high white count, but if they do have a very high white count, does that change our thresholds? And so there's a lot of different factors to weigh in, and to rely on one number alone, I think, is really a mistake. And perhaps, I don't want to, it was published in New England Journal of Medicine, but perhaps something I have to think about moving forward in designing trials and thinking about, do we really base it on just this number? And then the last thing I say, I'm really interested in hearing from the group as well, and I think we have time for that. But certainly in TaxiCab, when we looked at the ability of platelet count or INR to predict bleeding, they themselves might not be the right test. There are probably better tests out there that either exist currently or don't exist and need to be developed to help us to predict the risk of bleeding, and perhaps in the future using other tests to guide our transfusions might be better. But I open it up to the group. Oliver, I know you had put in a comment about the red cell transfusions in a patient with respiratory failure. So interested to hear what you have to say, or anyone else from the group, please.
So as Avi pointed out, there is normal lactate and SVO2 suggesting that the balance between DO2 and VO2 is met. And so I'm not sure that there's no one has shown a benefit of transfusing in a patient who has a normal DO2, VO2 balance. So I know that there's no randomized trials using these markers as triggers for transfusion. But in the absence of randomized trials, I think that we can lean on the physiology to say, well, this patient, I can't see what physiologically we would want to improve in a patient who already has normal DO2.
Oliver, I'm just going to pick up on one thing while someone else comes in, but I think you made a really important point there about, the trials that we've been done. And again, I know there've been a lot of randomized trials. Stacey will be aware of this as well, a lot of randomized trials as a whole. I don't think they've ever identified superiority for red cell transfusions. So, we're often talking about non-inferiority, but they haven't identified that, where they might have benefit. Actually, in 1 or 2 trial settings, they've actually identified harm if you're a little bit more liberal. And so I think that's making me question. There might be, again, it's in the adult setting, but there might be quite a big trial coming out later this year, which is looking at adults with myocardial infarction, cardiac disease, where the trial has been set up as superiority. And so this might be an example where we really want to see if there's a superior benefit to red cell transfusions. Maybe this has some implications for some of the children with congenital heart disease. But I agree with your comment, Oliver. I think very fair.
Other thoughts from the audience? Peter, do you want to just for a moment, if you're at liberty to discuss a little bit about the Petra data collection and what we might learn from that, speak about it for a moment?
Well, I should probably let Avishai talk more about it because he's the chief investigator in the UK for it, so he might want to talk about it if he's still there. But there is data collection. I mean, it depended because it's just purely observational. It's dependent on whether that has actually been done as part of the care, but it is potentially there as pre-transfusion and post-transfusion lactate and SVO2. Sorry, I was having a problem with my typing. I put SVCO2. You can tell I was completely pressing the wrong buttons. SVO2. So we might get something from that, but that's dependent on people actually measuring it. And of the children I've already put in, not all of them have had that measured pre and post. So the data may be a bit patchy, but it will give us something perhaps. Yeah. I was also I put another comment about the anemia, which I think is a really important one about what happens once they leave PIC, which I really don't think we thought very much about, because you send out say an 8-week-old with an hemoglobin of 74, you think you've done a great job, and then if you think about it, their hemoglobin probably isn't going to go much higher and probably could go quite a bit lower in the next couple of months. Who's picking up on that? Who's following that up? Because it isn't me. I certainly know that much. It isn't me. Is someone actually watching out for that?
Yeah, and we have audited that in Oxford as well, because that was something we were concerned. And we looked back over several years, and actually it was very rarely, and it doesn't mean that nobody has done anything about it, but it was very rarely flagged up in patients' discharge letters to say that this was identified, has been worked up, and treatment started or not started, or any decisions made around that. So I agree. I think that is a big area of concern.
Peter, I just echo that as well. I think what happens to that anemia afterwards, you might be interested, but certainly in the adult ICU situation, there are randomized trials being planned, ongoing at the moment, that are looking at giving intravenous iron, and the other way to actually increase hemoglobin is a red cell transfusion. But what we're looking at here, and I stress again, only in the context of a randomized trial, and this is only in the context of post-operative anemia. And I think the other population, I think, Peter, in your chat, you mentioned, you know, the young infants where we're not so sure about whether they've hit the nadir of their hemoglobin. I think the other group that worries me a lot are some of the younger adolescent girls, where I think we know there's much more data around iron deficiency anemia, and you know, then they've come into PICU, lost blood, and I worry particularly about what happens to the follow-up of the anemia in that situation.
I mean, and Peter, I would agree with you in terms of thinking about those patients on discharge, and then following up, trying to treat or improve their anemia. If those patients are then coming in for an elective operative procedure, is their anemia recognized before going into potential operation? And so it is something that I think we're not as good about identifying and even upon discharge and following. So I think that that's a good one of the hallmarks of what we're trying to, at least in SABM, increase that awareness of anemia, and how can we think about managing that and treat that too. I think that's really an important concept that we really haven't tackled.
No, I agree, Stacey. And then there are all sorts of very simple, pragmatic questions. What's the right dose of oral iron to be giving? You know, there's a lot more work that's coming out at the moment. It's largely based around kind of what I might call physiology, iron absorption studies. But, you know, maybe the traditional doses of oral iron may not be the right ones. And even something so fundamental, actually so simple, we don't really know.
Interestingly on that, I mean, we do give iron to quite a lot of our young infants, and we're actually going to do a service evaluation to try and follow up what happened to them, so that they may be being discharged with hemoglobins of, you know, high 70s, 80s. But we've started them on iron, and Simon's right. It'd be quite interesting to go back whether some of them have been started just on the prophylactic dose, some of them have been put onto the treatment dose, and then actually seeing what's happened to them, because we don't know. It's just, it felt more comfortable for some of them when they were very young that we were actually supplementing them. And these are not neonates who've come from neonatal units with preterms where they've already been put onto supplementation. These are just, you know, your children coming through at that age, and then it just, I don't know whether it achieves anything, we'll see, but it will be very much a service evaluation. So I'll let you know in due course once we've actually crunched the numbers.
It's interesting how, you know, we learn about case studies really like from medical school to demonstrate kind of clinical applications of it. And then in the discussion, you just realize how complex the situation really is in terms of transfusion, and why getting to our next speaker, Kate Stefan, is going to talk about, we all have this general idea that we can do better about understanding blood transfusions, and we can do better in terms of how we transfuse our patients, even though we don't have absolute consensus on exactly how to do that. But Kate Stefan is an associate professor at Stanford, and she is also a pediatric intensivist there, and really an expert in implementation science, and with a specialization in patient blood management. So I'm excited to hear you talk about how do we get people to try to do the right thing. Hey, I think you're on mute, or at least I can't hear you.
I can't hear you either.
You have a moment though.
Thanks so much. Oh, the dreaded mute. I'm so sorry.
That's okay.
Okay, you'd think I would know what I was doing by now. Can you see my slides? Great. Okay.
Yeah.
Hi, so my name is Kate Stefan. I have no financial disclosures. What I'm hoping to do in the next few minutes is to briefly introduce people to the concept of implementation science, to discuss how implementation science has been used in patient blood management, and to offer a framework that may be helpful to help incorporate a little bit of implementation conceptually into your PBM practice. I'll apologize in advance. I am still at home, and my 3-year-old and baby are likely going to make noise at some point, and I apologize. It's still very early here on the West Coast in the US. I couldn't get him out of the house. Anyway, so just a bit to begin. It takes roughly 17 years to get about 14% of what is sort of known to be evidence to the benefit of patient care. This is something that's been looked at and studied. And while I have this continuum that moves from basic science to early clinical studies that are designed to establish efficacy and eventually effectiveness of interventions, really the sort of translation of evidence into actual routine clinical practice is something that's been more complex. Initially, people thought that doing efficacy and effectiveness trials automatically would sort of translate to implementation, but we found that just isn't the case. And so really there's a huge research to practice gap where patients fail to get effective treatments many times. They may receive care that isn't needed or potentially harmful. And this leads to a waste of scarce resources, which I think is particularly important in this patient blood management space. Implementation then represents sort of a fundamental challenge we have to optimizing care, and one that I think is important to think about. So what is implementation science? The many definitions, one of those really well recognized is this one at the top from Eccles. It's the study of methods to promote the systematic uptake of research findings and evidence-based practice into routine practice, and then to improve quality and effectiveness of health services from that. A more simple way to think about it, though, is research to inform how to make the right thing to do the easy thing to do. That comes from Carolyn Clancy at the AHRQ. When I think about implementation science, sort of in the context of what we typically do in medicine, usually what we're looking at is taking sort of what we think is an evidence-based practice and looking at the patient's outcomes, whether it's their sort of clinical status, their symptoms, their function, whether or not they're satisfied. In some cases, we will look at service outcomes, things like efficiency, safety, effectiveness, equity, whether or not we're able to deliver something that's timely or patient-centered. Implementation science really fits in this other space in between, however, where we look at sort of specific strategies to get people to use the implementation or the evidence-based practice, and then analyze these outcomes, whether or not something is feasible. Do people find it acceptable to provide? Do people take it up into their practice easily? Are they able to deliver it in the way that's intended? That's fidelity. Penetration is sort of how deeply something gets embedded in practice. Costs is really obvious. And then whether or not that implementation is sustainable over time. And so these questions are really the ones that we're interested in implementation science that really didn't eventually translate to our patient outcomes. This is from Jeff Curran, who conceptualizes implementation science, I think, in this very simple, elegant way. So the innovation or practice is the thing that you're interested in doing. Effectiveness research looks at whether the thing actually works. Does it really help people or achieve what you wanted to? Implementation research looks at how to best help people do that thing. And the implementation strategies that we use are the stuff we try to help people do the thing. And so really what we're looking at is not the intervention itself, but the stuff we're trying to get people to do it. I am not going to moderate the chat right now, but we'll get to the questions if there are questions in the chat at the end. One of the questions that frequently comes up is what are the differences between implementation science and quality improvement? And so the way I typically think about that and the way most people think about that is quality improvement really looks at a specific problem in a specific system where you're currently working. Implementation science takes a slightly broader approach and looks at evidence-based practice that is underutilized sort of more globally or in a larger sort of a system. The approach that's typically used in quality improvement is rapid improvement cycles or PDSA cycles, whereas in implementation science, we look more sort of at identifying gaps in our context that are preventing us from having good quality of care, looking at barriers and facilitators at multiple levels to sort of assess and analyze the situation before we implement improvement, I guess, strategies. In quality improvement, evidence may be present, but isn't necessary, not always there. In implementation science, in the traditional sense, it's really thought to be necessary, although in our case in pediatrics, sometimes we're sort of doing the best with what we have. There are many sort of challenges to implementation that you'll recognize, I think, here. These include organization and leadership support for any intervention. Involvement of stakeholders could be limited. We may have sort of limited knowledge about the evidence-based interventions on the part of our providers. The interventions may not fit with existing practices and patient needs and need to be modified to sort of fit those needs. When research is typically done, there's really oftentimes little attention paid to the external validity of the intervention. And so need to think about sort of how to translate that intervention that's done in the research context to one that you can really apply in the work systems that exist at the bedside. And the last thing is that we all work in complex systems that have multiple levels and need to think about those and sort of how any intervention impacts those levels. To do this, implementation science offers a few different tools. These include frameworks and models, strategies, and outcomes. We'll talk about those individually. To start with frameworks and outcomes, I am simplifying this fairly significantly, but frameworks are typically thought of as sort of having three different purposes. One is to just describe implementation, to look at something that's been implemented and to try to explain how and why it works. We have determinant frameworks, which are looking to identify and understand barriers and facilitators. Those are oftentimes ones that are sort of most useful because you can use them to sort of assess a situation before you go and implement something to try to sort of make decisions in terms of how to go about implementing it. And then there are frameworks that help you evaluate implementation efforts, something that sort of has already been implemented. If you want to go back and assess sort of, is it working, how well or how not well is it working? Evaluative frameworks will help you do that. When we think about strategies, there are really catalogs of interventions that have been developed within implementation science. I'll show you one of the most common ones in a second. And then there are sort of various methods in which we can sort of select different strategies that may or may not help us implement things. Those strategies or those selection tools can be fairly complex to implement or relatively straightforward. I'll talk about sort of one of the more straightforward ones in a moment. But sort of to give you an example of sort of these catalogs of strategies, this is an example of this is the ERIC categorization. So we have sort of multiple different categories of interventions that are strategies that you may use. There are things that will make sense to people, things like using evaluative and iterative strategies to do things like identify barriers, provide audit and feedback, all the way to things like changing infrastructure, the actual physical structure, equipment that we use, credentialing, accreditation, licensing standards. And so these sort of catalogs of interventions really can help you sort of go through and think about what's possible in terms of implementation. Obviously, you shouldn't be using all of them, but really can be helpful in terms of identifying strategies that are sort of meant to do a specific thing, depending on whether or not you think that thing is needed for a particular intervention. Lastly, we have implementation outcomes, and I touched on these a little bit a few minutes ago, but these are things like acceptability, adoption, appropriateness, feasibility, fidelity, implementation costs, penetration, sustainability. I will say that sort of measures of these things are still in development, and so sometimes we don't have the perfect measure to look at a situation, a particular outcome within the clinical context that we're working in. A lot of implementation science has been done within the behavioral sciences and within social work. And so sometimes these measures are not exactly translatable to clinical medicine, oddly enough. And that's sort of some of what I'm interested in, sort of looking at how to ensure that we're measuring these things in what we're doing well. A couple of sort of studies looking at implementation in patient blood management. There are two sort of systematic reviews, meta-analyses that I wanted to touch on. This first one, published in 2020, looked at barriers to use of PBM guidelines, and their goal was to identify common barriers and strategies that were used to implement PBM guidelines. They used a restrictive review approach, which this is my first time sort of looking at that, but it's sort of more a liberal sort of approach to doing systematic reviews. They use something called the CFR framework. The Consolidated Framework for Implementation Research is really one of the most common, and I would say sort of the most commonly used implementation science frameworks to code the different barriers that were identified in these studies. And then they used the ERIC catalog, I guess, of implementation strategies to code the strategies that were used. They included 14 studies and found that the commonly reported barriers were things like access and knowledge to the information needed to implement the particular PBM guidelines. Knowledge and beliefs about PBM were really a significant issue. And then tension for change, people just not thinking that it was particularly important in their practice to pay attention to. There are really a wide variety of implementation strategies that were used in these studies. There were 25 different strategies that were used across the 14 studies, and up to 7 were sort of done simultaneously in any given study. The ones that were identified or that were used most commonly were educational meetings, audit and feedback, developing educational materials, conducting local consensus discussions, quality monitoring tools, and reminding clinicians to use PBM strategies. Only one study actually reported using an implementation model or framework, which sort of demonstrates sort of the need, I think, in this area to sort of be more systematic in their approach to doing these types of things. But 50% of the strategies that were selected actually matched barriers as per the ERIC catalog. One of the things that the ERIC sort of effort tried to do was to sort of provide some sort of framework to match particular barriers to a strategy. And so I'm happy to provide that reference if people want it. But of those strategies, of those strategy used, half of them matched the barriers that were identified in the studies without people even trying. So that sort of speaks, I think, a little bit to both the sort of intuitiveness of this, but also sort of the opportunity to do a little bit better, since 50% is only half. The other study that I wanted to highlight was a meta-analysis, which was a study of study interventions to promote restrictive transfusion. In this meta-analysis, the primary outcome was to look at the proportion of patients transfused. They included 84 low to moderate quality studies and then 3 RCTs among those that were sort of not of particularly high quality, hence the moderate quality. 52% of the studies included in this meta-analysis explored a multimodal intervention. So when sort of multiple implementation strategies were used all at once, which is very common and thought to be actually more effective than just using a single strategy alone. 33 of the studies looked at the odds of transfusion and found that there was a reduction in the odds of transfusion using the implementation effort that was used. When they pooled other specific outcomes, they found improvement in inappropriate transfusion in the studies that looked at that, an improvement in the number of RBC units per patient, improvement in the pre-transfusion hemoglobin, and in length of stay, again, in the studies that exclusively looked at those particular outcomes. The greatest impact that they saw was when studies would use a protocol or algorithm-based method, or when they used a multimodal approach. And again, that's something we see throughout implementation science, that sort of a multimodal strategy is sometimes more effective than one that we're just using one implementation effort. There was significant heterogeneity in these studies and sort of evidence of publication bias as well, given the strength of the studies. We've talked a good bit about the taxi and taxi cab guidelines, and one of my goals is to sort of implement right now in my implementation work the taxi recommendations. To sort of start looking at this, we did a qualitative study looking at sort of how change occurs in ICUs, and this is a study of, I guess, 8 US pediatric ICUs, looking at sort of how change actually happens. And we found that there were sort of 3 sources of change. One, there was either a motivated individual or a group of individuals who wanted to change. There was sometimes an external sort of impetus to change from the hospital, or sort of from something sort of larger outside the hospital, or there was some sort of negative sort of outcome that sort of pushed people to change. Then we had sort of from there sort of 2 necessary sort of factors that sort of determined whether or not change actually happened. One was sort of buy-in from unit leadership and processes to actually implement the change. And the other were sort of determinants that came from the individuals who are implementing the change at the bedside, the nurses, physicians, other providers who were actually asked to implement the change. And the sort of determinants that were important for those people were the evidence for the change, their underlying beliefs around that change, the experiences that they had had in the past, the perceived benefit versus the effort required to actually use the thing. Oh, sorry. The time it took and any competing interests that they had. And those things I think are really important to think about when we think about implementation, because this is really the thing that sort of, I think, helps or hinders us at the bedside in terms of doing something. If you had these 2 things in place, then separate efforts were needed for facilitation, implementation, and then ultimately sustainability. And those always obviously happen within the ICU, with the hospital environment sort of influencing it. But really, these 2 sort of triangles were the key pieces to make the rest of this go, per se. One of the other things we did was to sort of look when we were thinking about implementing the taxi guidelines. at sort of what specific things impacted implementation, and divided those into sort of different buckets. One was the innovation, the guidelines themselves, the recipients, the people who were implementing the guidelines, the overall context, and then sort of what was needed to facilitate that change. This is published, and happy to provide the reference. I realize I didn't do it because it's awkward to reference yourself, I guess. But really sort of to divide it up and to sort of think about the things that were impacting these four sort of categories. I won't go through these in detail since we're short on time, but I'm happy to, again, share that reference. From that, we then looked at sort of the barriers that we identified to implementing the guidelines. We categorized those within the CFIR framework and came up with implementation strategies that were intended to sort of address those strategies using an implementation sort of tool called intervention mapping. And so those we came up with for building consensus among both stakeholders and providers, providing education to providers at the bedside, engaging champions in multiple ICU roles, and not just having one physician champion, but having a nurse champion, a nurse practitioner, a physician assistant champion, a resident champion, so trainees to sort of mobilize those individual roles individually. Thinking about using computerized decision support tools, and then monitoring impact on transfusion over time after you had implemented something. So this work is sort of ongoing, and we're working on sort of implementing these things in settings. I know we'll go in a few minutes, okay, bud? Sorry, promised it would happen. So this is a sort of framework, I think, though, that is helpful in terms of thinking about implementation when you're trying to do it on your own. And these things include assembling an implementation planning team that's multi-professional, assembling resources for implementation, auditing your baseline practice prior to implementing things so you know sort of what's going on in terms of practice, assessing local barriers to implementation, sort of to determine sort of what sort of things may prevent things from being implemented. Interacting with stakeholders to gather contextual framework to inform selection of strategies, developing implementation tools that are specific to your barriers, and then having an implementation plan to have specific sort of intentional specification around identifying strategies, roles and responsibilities people will have, the timelines that you're going to use, and then having process and outcome measures sort of identified upfront so you know the impact of the change you're making. I'm gonna stop there and thank all of you. This is sort of just a cartoon about what implementation science, and I think what our job at the bedside sometimes feels like in terms of implementing research. And so I'm happy to take other additional questions from here. Glad to see that all of the questions are about IV iron, and I don't have to answer those.
Well, thanks so much, Dr. Hey, is it Stefan or Stefan?
It's just Stefan. It's pretty boring.
Okay, we will make it a little bit fancier. Well, thank you so much. And with that, let's see, I see all the questions about IV iron. Stacy asked, how many formal pediatric patient blood management programs are in the hospitals? They don't currently have one at UMass. We have one in Colorado. Do we want to answer the short question in terms of whether or not? Marianne says there's a bi-campus one at New York Presbyterian Hospital. So Columbia and Cornell combined. Peter Davis says they use oral iron rather than IV iron and almost exclusively in infants. There's probably a lot of opportunity in having like patient blood management programs kind of like help driving the implementation, right, at hospitals. I totally agree. So I wanted to be respectful of everybody's time since this is like a 1-hour webinar. It's 9:04. This recording will be available on the BloodNet research page. I wanted to thank all of our speakers for taking time out from holiday and from watching a 3-year-old and a baby and their busy work schedules to be here. And thank you for our all our participants. Everyone's on like the forefront of making change in blood management. So thanks everybody. Thanks so much for joining us.
Thank you, Michelle.
Thanks.